Hello, and welcome to the IGCS Education 360 podcast. I'm Dr. Kathy Hahn, a radiation oncologist from Canada and the chair of the Radiation Oncology Education Working Group. On today's podcast, we will be taking a deep dive into the translational circulating tumor DNA findings from the Phase 3 randomized CALLA trial, which evaluated the addition of durvalumab to chemoradiation in locally advanced cervical cancer. We're pleased to have Dr. Jyoti Mayadev, a radiation oncologist from the University of San Diego and the leader in the CALLA trial, with us to discuss the trial findings. Jyoti, thank you so much for taking the time to join me today for this special podcast.
Hi, everyone. Thank you so much for talking about a very important topic in locally advanced cervical cancer. So I'm happy to be here and excited to review all the data and also give some clinical pearls.
Thank you. To start us off, can you walk us through the clinical problem that this study is trying to solve? Why relapse after chemoradiation locally advanced cervical cancer remains such a major unmet need, and where biomarkers might fit into that gap?
Locally advanced cervical cancer, as many of us know around the globe, just continues to remain a major threat, with more than 600,000 new cases diagnosed per year around the world. And cervical cancer is one of the few solid tumors where definitive chemoradiation can be curative, but relapse remains still common. And even with high quality image-guided brachytherapy, concurrent cisplatin, and even IO, 30 to 40% of patients will recur, and then outcomes after relapse remain poor. And so our main problem is that current post-treatment assessment tools like pelvic exam, MRI, CT, PET detect recurrence only once macroscopic disease is present. And by then, the window for cure has largely closed. So what this is where biomarkers, and particularly ctDNA based residual disease or MRD assays, may fit. So, HPV-driven cervical cancer circulating HPV DNA can reflect residual tumor burden, and informed tumor assays such as that we used in the CALLA trial, the Next Personal, go a step further by really tracking patient-specific somatic mutations. And so the unmet need isn't really just detecting relapse earlier, it's identifying persistent disease while it's still biologically targetable.
Great, and thank you for explaining that. Now, for listeners who may not be as familiar with the tumor-informed ctDNA approaches, can you elaborate a bit more on the ultra-sensitive Next Personal assay that you use, how that differs from the HPV ctDNA assay, and why did you decide to evaluate both approaches?
Yeah. So, just to kind of recap, in HPV-driven cervical cancer, we really have two biologically distinct minimal residual disease strategies, just like you're alluding to. And the HPV ctDNA assays detect circulating viral DNA. Typically, it's HPV 16 or 18, and these are the most common genotypes that are found in cervical cancer. And these are a function of tumor burden markers, and they're tissue free, they're highly specific and virally driven disease. Now, in contrast, other assays such as that which was used in the CALLA trial called the Personalis Next assay is different because it requires tissue, and it really looks at patient-specific somatic mutations. And in fact, that one can detect over 1,800 different mutations identified from the tumor itself. And so it really allows us to measure true molecular residual disease and potentially understand evolution after chemoradiation or immunotherapy. And so the key difference is really HPV ctDNA measures viral oncogene fragments, and tumor-informed assays measure patient's tumor genome. And so the tumor-informed assays may potentially provide a higher confidence for minimal residual disease, and that's why we used it in the CALLA trial. But we also wanted to look at the HPV DNA because that is what's been mostly published in cervical cancer. And I know Dr. Hahn has had publications herself on this.
And it's really great that the trial looked at both approaches and compared both. Now, looking deeper into the tumor-informed assay, out of the 770 women randomized in the CALLA study, 241 provided informed consent for genetic sequencing and had the appropriate samples collected. the biomarker accessible population included 185 patients at baseline, which is about 77% success rate for whole genome sequencing and panel design. Can you comment on the success rate and are there rooms for further improvement, how that might compare to, again, the circulating HPV DNA approaches in terms of that success rate?
Yes. And I actually, view a 77% success rate for whole genome sequencing and a personalized panel design in a global phase 3 trial as being quite strong. Just to reiterate, that entailed essentially archival tumor, and that's retrieval across international sites. You have to have adequate tumor cellularity, a high quality DNA extraction method, and successful whole genome sequencing. Then there's bioinformatics that are involved in terms of data transfer and really custom assay manufacturing. And so it is operationally complex. And so in that context, the roughly 3 out of 4 consented patients, uh, particularly in a multi-center global trial like CALLA, was quite respectable. And now, if we ask another question, is that, well, how does that compare to HPV ctDNA approaches? Now, HPV ctDNA approaches do have some inherent operational advantages. They do not require tumor sequencing. There's no custom assay design. There's no need for sufficient tumor tissue. And so you get faster turnaround. And so logistically, HPV ctDNA assays do have a higher feasibility rate at baseline. And so that's kind of a little bit of how we thought about the success rate on the CALLA trial.
And certainly, I fully agree with you. The 77% success rate is quite impressive, especially in this global context. The other striking result is that both the circulating tumor DNA and the circulating HPV DNA were detectable in nearly 99% of patients at baseline. Now, what does that tell us about tumor biology in locally advanced cervical cancer? And does this then make ctDNA particularly attractive as a clinical tool in this setting?
Yeah, a baseline detectability near 99%, I agree, is a big deal. And it does tell us things about locally advanced cervical cancer biology and why these blood-based biomarkers are actually quite appealing. And so it could be that, inherently in the biology of locally advanced cervical cancer treated with chemoradiation, there is a high shedding, high burden. And so, as many of us on the call and the podcast know that there's after, being treated with radiation, there's tumor DNA entering the circulation. And that's why, both the tumor-derived ctDNA and the circulating HPV DNA are usually detectable at diagnosis in cervical cancer. Um, Biologically tractable disease with cervical cancer does also allow us, you know, in general, to have a good liquid biopsy tumor exposure. And it's a strong starting point for kinetics. It's very important, as all of us know, that if you have a patient that has a baseline test that's 99% and they have a positive tumor, this is it's dynamically important as opposed to in other cell types. You see baseline rates of around 60 or 70%, and so it allows us to start looking at kinetics, clearance dynamics, how things change during chemoradiation. Is an early drop or clearance potentially powerful for treatment effectiveness? um, Even post-risk treatment stratification. So all of these things are quite attractive in cervical cancer.
Right. And you showed us that patients with higher baseline ctDNA levels above the median had worse progression-free and overall survival. In contrast to circulating tumor DNA, baseline circulating HPV DNA was not consistently associated with progression-free and overall survival. Why do you think circulating HPV DNA was less predictive at baseline and only became more informative after treatment?
Yeah, I mean, baseline circulating HPV DNA just behaves differently. HPV DNA is a viral signal. It's present in nearly all tumors in cervical cancer. Well, 80% if you're looking at HPV 16 and 18. And it's around because the tumor is HPV driven. So, at baseline, it was positive, but if you then start looking at, well, how do things look in terms of prognosis, or how a patient will do after chemoradiation if it's, say, negative or positive, then I think that's where the ctDNA quantity can reflect overall tumor burden, tumor proliferation and turnover, even genomic instability, and even potentially shed light into potentially, aggressive clonal architecture. So those are, I think, the key differences between the two, and it could shed light on why we saw those differences, i.e., that circulating HPV DNA was less predictive.
Mhm. Right. And you also show that patients with detectable post-treatment circulating tumor DNA at cycle 3, day 1 has significantly worse progression-free and overall survival compared to those with undetectable post-treatment ctDNA. And that ctDNA detection preceded clinical progression by a median of 164 days, which is about 5.5 months. How do you envision this kind of lead time being used in clinical practice?
Yes, I think we have a real opportunity. A median lead time of roughly 5 to 6 months can be potentially clinically meaningful, but if we start looking at it in terms of how we can translate it to clinical practice, which I think is still lacking. So there are, intelligent ways that we can come together as a community of clinical trialists, clinicians, and innovators to start thinking about how we can envision this lead time being used. You know, there's number one, there's potential risk stratification um, for even escalation trials. So post treatment ctDNA positivity, we could identify these, and we did on the CALLA trial, as being a very high risk group. So instead of waiting for radiographic relapse, where cure can be, potentially concerning, or there's more burden of disease, we could start looking at, potentially having trials that enroll ctDNA positive patients into early intervention, potential different consolidation or maintenance strategies, studying IO intensification, perhaps antibody drug conjugates, targeted therapies. And I think the most important thing that we learned from this, one of the most important things, is that we can start looking at trial enrichment, and not um, and potentially, enriching the population for our strategies after chemoradiation that would potentially benefit the patients at highest risk. There's also, number two, we can start looking at like adaptive surveillance. So patients that are positive, do we increase imaging? Do we have focused evaluation of areas that are a high risk, in the past, potentially periordic areas or distant disease? And so we really need to be thoughtful about this as a group moving forward, how we're going to use these MRD detected interventions with evidence. I think, Dr. Hahn, sometimes I also struggle that if patients come into clinic and say, hey, I'm now after chemoradiation, I got this test, what do I do? And right now we're in a quandary. What is the threshold for positivity? Are patients just going to be positive, and then, they relapse, and we have this lead time? So there's a lot of questions that we hope to answer in the future.
Right. And out of curiosity, are you using ctDNA to guide surveillance or treatment at this point in clinic? Because I know it is available commercially in the States.
Yes, it is, available commercially. I am not currently using this in my clinical practice because I don't have good data to drive the next steps forward. And this is where I'm really kind of, appealing to all of us on the call, as well as, the diagnostic companies, the pharmaceutical companies, partners that we have in this space, that it's very difficult if we have tests and we don't know what to do with them. So I think this is where we could really, think of some innovative strategies that could benefit all of us.
Right. And you've mentioned a lot of potential utilities of ctDNA. If you could design the next study building upon your CALLA translational findings, what would it look like, and what questions do you most want answered next?
Yeah. The ctDNA is really looking like a tool that can move us from kind of a a one size fits all treatment intent to treat population into a more risk adaptive therapy in locally advanced cervical cancer. But I think the key is really to be precise about what, where we need to go. And so these types of trials, for example, if we could help immediately with this and we have the answers, we would look to trial enrichment. So using ctDNA for trial enrichment and these risk adaptive designs. So for example, let's say, for example, a patient is ctDNA positive after chemoradiation. It could be at the end of treatment, although in the CALLA trial, we did show that there are a small subset of patients, around 10%, that will, go from positive to negative. So I think 3 months post chemoradiation is a good time point. That's a time point where we look now to imaging such as the PET CT or other clinical decision makings. So that would represent an actionable group. And then we could potentially look at intensification strategies or at novel therapeutics where it would potentially, improve outcomes for these patients. So it would be a randomized trial where if you have a patient who has ctDNA positivity, then they move on to a different type of intensified or systemic therapy, targeted therapy, novel therapeutic versus our current standard of care. I think another option that we could consider is that we found on the CALLA trial that if patients became ctDNA negative or normalized their ctDNA at 3 months, regardless of use of maintenance IO therapy, in the CALLA trial, it was durvalumab, patients did extremely well. And looking at long term, are these patients then eligible for a kind of a de-intensification strategy? Since those patients did so well on the trial, even these high risk patients, we're looking at about 86 to 90%, where they continued to have progression free survival. So this is quite encouraging.
Right, especially when the negative predictive value of ctDNA was quite high in your study.
Exactly, exactly. It really gives us an opportunity to structure these new clinical trials, and exciting questions about, treatment intensification. I call it intensification, but it doesn't necessarily need to be intense. We just need it to be smarter. You need to have, molecular targets. We need to have it more personalized for these high risk patients. And then another option is some a de-escalation, avoiding therapy. But we have to be cautious. We have to look at predictive values. We have to look at risk. We have to define cohorts and balance this into frameworks that will move forward with clinical trials and then ultimately be able to be translated into the clinic.
Right. Now, I found it quite interesting that the association between circulating HPV DNA at cycle 3, day 1 and outcomes appear to be highly sensitive to the cutoff used. So when a cutoff of 0 was used, i.e. detectable or non-detectable, detectable circulating HPV DNA at cycle 3, day 1 was associated with worse progression-free and overall survival in the chemoradiation arm, but not in the durvalumab arm. However, when a higher threshold of greater than or equal to the median was used, elevated circulating HPV DNA at cycle 3, day 1 was associated with worse outcomes in both treatment arms. What do you think might explain this difference, and how should this inform the selection of clinically meaningful circulating HPV DNA cutoffs in future studies, let's say if they don't have tumor tissue readily available for the tumor-informed assay?
Yes. The results do change, as you alluded to, when the cutoff changes. And so it could be due to a couple things, detectable versus not at cycle 3, day 1. It could be too close to the assay's noise floor. So when you set the cutoff at 0, i.e. any detection is positive, then you're potentially lumping together very low level signals near the limit of detection. And a truly high post-treatment burden. And so this could dilute the prognostic signal, especially if low-level detection includes a meaningful fraction of these biological non-events, which could be transient DNA clearance that's to be underway or even sampling variability. Number two is durvalumab or IO agents may shift what this meaning of low-level detectability is. So, we need a more kind of biological explanation for detectability. Because, for example, IO could increase transient detectability, but without representing true viable residual tumor. It could be immune mediated tumor cell death, antigen release, delayed clearance kinetics, even different inflammatory necrosis dynamics affecting these viral DNA releases. So at a binary cutoff, 0 or 1, with 0 not being detectable, the Durva or IO could create this more kind of low positive cases that truly aren't high risk. Um, Number three, there could be the threshold acting as a kind of a high risk burden filter. So when you switch to, say, for example, a greater than or equal to median, we're no longer asking the question, is anything detectable? It's kind of asking, well, is post treatment levels still elevated, and what that means is it's substantially elevated. And so these could explain all of this, plus their statistical analysis factors, cutoffs chosen post hoc that could look sensitive, but exploring multiple thresholds. I think clinically speaking, though, it does bring up a point of what should the threshold be? What is a clinically meaningful threshold? Now that these ultrasensitive assays can detect such small somatic mutations, we have to determine, what is noise. So all of this is unfortunately bringing up more questions.
Yeah, it's certainly such an exciting field. Now, one final question. What do you think are the biggest barriers to integrating ultrasensitive circulating tumor DNA testing into routine management of locally advanced cervical cancer in the future? Is it access, cost, or knowing what to do with the result?
I think all three of them. I think access, cost, actionability. I think the biggest barrier right now is knowing what to do with the results in parts of the world where we have these options. Number one, actionability, I think, is our greatest concern and our greatest opportunity. And now that we have these highly sensitive tumor-informed assays, we can detect these molecular residual disease, as you rightfully said, and as CALLA showed, months, 5 to 6 months before imaging. But right now, there's no validated, MRD directed intervention just yet. So we don't have prospective data showing us that these molecular persistence residual disease would translate to us having an action in clinical trials that would improve survivals. So I think without a defined actions, clinicians hesitate appropriately to order a test that might cause some anxiety without changing management. So it's a problem, but it gives us a major opportunity because now we've kind of defined the problem. I think, Dr. Hahn, and you continue to bring this up and do amazing work in all of this, that access and global equity continue to be major structural barriers. And so the tumor-informed ctDNA assays, as we talked about on the call today, require high-quality tumor tissue. They require centralized sequencing infrastructure, sophisticated logistics and data management, and rapid plasma processing, because people don't want to wait, weeks for a result. And so these might be easier now to deploy in academic centers, but we have to remember that the global setting is where cervical cancer burden continues to be the highest. Cost, again, follows utility. These ultrasensitive tumor-informed assays are expensive. So hopefully over time, technology will structure these assays to be more accessible in the future, so that we can really use the intervention of these MRD assays for directed clinical trials And for us to define what a positive test means and how we can make appropriate action as a clinical community to improve survivals in locally advanced cervical cancer after chemoradiation and IO.
I fully agree. Excellent points. And this has been a truly fantastic conversation. Dr. Mayadev, thank you so much for sharing your knowledge and experience with the IGCS global community. I found this session so valuable, and I'm sure our listeners feel the same way. To our listeners, thank you so much for tuning in, and we encourage you to visit IGCS Education 360 Learning Portal for all our educational offerings. Thank you.